that have come along for development, you're very welcome indeed. And as I always say at this point, if anybody has any questions after the meeting, then there are obviously a range of executives, or indeed myself. If you have any questions or want to follow up on anything, then please make contact with us after the meeting, and everybody would be very pleased to assist you. We've got a very packed agenda today that we need to get through, and it's on a day when I think it's fair to say that the NHS is under unprecedented pressures, and I mean that quite literally. I think we've never seen the pressure across such a breadth of our services, and I'm talking about the system. It's not just what we see on the front page of the news, which is obviously the urgent emergency care, but across every part of the health and care system, whether primary care, whether in secondary care, social care, every part of the health and care system is under such pressure. And because of that reason, there may be one or two of our colleagues that need to dip in and out, because apart from the acuity of the patients, apart from the number of patients and the demand and capacity problems, we've also got the ambulance dispute today that we're dealing with. So a number of our colleagues, especially our operational clinical colleagues, may have to dip in and out for meetings to try and keep things rolling along. So there's no problem with that. We recognise the pressures that you're all under. So thank you for doing what you're doing. And I think it's reasonable that I recognise from the chair the context that all our staff are working in, whether that's with us or across the whole of the health and care system, is just so difficult, so difficult. That's everybody. And I'd like to recognise that before we kick off. So anyway, with that, we'll move on to any apologies that we have. I'm aware of an apology from Matthew Hall, our Chief Operating Officer. Jill, do we have any other apologies, please?
No, we don't.
Thank you very much.
Oh, sorry, I should probably say Julie, actually, Julie Snell.
Oh, yes, indeed. Julie Snell sends her apologies as well. My apologies, and thank you for that, Jill, for reminding me. OK, if we could then move on to the minutes of the meeting, which was held on the 9th of November. Does anybody have any matters arising or matters of accuracy before we move on, please? Janet.
Yeah, I'm afraid it's a boring matter of accuracy, but actually I was present at the meeting. I think I'm where that line is in the middle. Somebody's deleted me.
I feel we could never delete you, Janet, so I'm sure we can ensure that's corrected for the record.
Thank you.
Thank you. If there's nothing else, if we can take those as a true and accurate record of the meeting. Thank you very much. And thank you, Jill and the team, Sharon, for another excellent set of minutes, which accurately captured what went on at that meeting. If we could then move on to the action log, please. There's a number of these that have already been completed and indicated as completed. The only one I was going to ask any comment about before I ask the floor whether any comments is number 4. Jill, have we received anything on that, please?
No, the national guidance hasn't been issued yet. It's usually issued probably in the next 2 weeks about reporting for, well, all the reporting relating to accounts and the annual governance statement. I do have a fairly regular catch up with counterparts across the system and including the ICS. So I will pick this up next time we meet, hoping that the guidance has been released by that point.
OK, thank you very much. So we'll keep that one there till it's complete. OK, with that, we'll then move on to, I've not been notified any questions from members of the public. Item number 7 is declaration of interest, which are all on the website. And in fact, there is actually an item on the agenda today, which then moves us on to number 8 of our agenda, which is a very important part of all our public board meetings, which is the patient story. And I'm delighted to welcome colleagues from sexual health, which I think, Natalie, will you introduce in a moment? Okay, yeah, good nod. Thank you very much. And I'm pleased also to have colleagues from one of our many services that doesn't often get aired, because it's a small but vitally important service that we provide to our communities. So I'm delighted to welcome along. I think I saw Tracy, and I think Tracy and Jackie are with us. I'm trying to look at 25, 30 faces on the screen, but you're very welcome. If I hand over to Natalie now. Natalie.
Thanks. Morning, everyone. So I'll only do a very brief introduction. So thanks to Tracy and Jackie, who, as you said, are here to represent the sexual health services today. Again, we haven't got a service user with us, but they'll go through and speak on behalf of, and they've got the voice of the service user captured. So I will hand directly over to them, and thank you both for joining us.
Hi everyone. For those who don't know, I can't see Tracy on the screen anywhere, so I'm presuming she's here.
She's here.
Bobbing about the screen. So I'm Jackie Griffin. I'm the safeguarding lead for Worcestershire Integrated Sexual Health, and I also manage the outreach nurse team. Well, our team, not just nurses, admin and community support workers support as well. So we've been around for quite a while, and our team has evolved over many years. More so recently with some additional funding that has been awarded to us from commissioners in 2021, which has helped us to do a bit more targeted support to homeless people, to young people not in educational training. We've set up a WhatsApp referral, self-referral line as well, and also, additional stuff around that. We also work with targeted postnatal women post-birth that are vulnerable, that can't access services. So our team is about accessing patients, engaging with very vulnerable and hard to reach patients who can't access mainstream health services and sexual health. With that comes the challenges of managing a very diverse and diverse population as well. So today what I've come to do is to talk to you about one of our patients who agreed to give her story. It's very, very powerful. So just to give you a little heads up before I start, that it is powerful and quite emotional. Obviously, I'm open to questions at the end. It also discusses partner agencies, and the partner agency involved in this, we work with lots of partner agencies, is a pause programme, which I can talk to you about after as well, which supports women to have a pause in pregnancy that have had 2 or more children removed permanently in care. So please stop me at any time if you want to ask anything, or I'm open to questions at the end. Do you want to add anything, Tracy?
No, I don't think so, Jackie. For people that don't know me, I'm Tracy Furler. I'm the Clinical Services Manager for Specialist Primary Care, which is sexual health and dental. But I'll pass back to Jackie now to tell the story. Thanks, Jackie.
Thank you. So this is the patient's story and a journey over many years. So Worcestershire Integrated Sexual Health, or WISH as we're known, outreach team asked one patient if they were happy to tell their story. The WISH outreach team are a small part of the story, and I'm very proud to be able to work with and support some of our most vulnerable people. The voice of the child and adult is very powerful, and this patient's lived experience is an example of never giving up to make a positive difference. So this is Libby's story. So Libby says, I first saw my sexual health outreach nurse when I was 12 years old, nearly 13. I met some boys who were 15 and I had sex with one of them. My school found out and told the social worker. The outreach nurse came to see me at school. I liked her straight away. She was kind and didn't judge me. She asked me how I was feeling about everything. I was upset and embarrassed. She did pregnancy tests and talked to me, so I knew that it wasn't my fault. I started being disruptive in school because everyone knew about what had happened. The boys told everyone. There were lots of meetings which my mum and I had to go to. My outreach nurse went to every one of them and told the social workers how I felt. At the time, I didn't know that having sex when I was under 13 was rape. The nurse explained this to me and I was put on a child protection plan. At the meeting, my mum was crying because the social worker said that she had neglected me. I don't know why, because my mum was doing her best to look after me and help me. She didn't just know what I was getting up to. The nurse came to my house after the meeting and talked to me about what contraception I could have, and me and my mum remember how good this was. The nurse told me and my mum to keep trying and not to give up. She said she is a mum herself and it's tough at times. My mum still remembers that. I don't think the nurse needed to come and see us after that meeting. She just did. She wanted to help us and she did. I didn't like the social worker. She kept telling me what to do and telling us that if my mum didn't stop me from going out and using my phone, then I would be put into care. The outreach nurse helped me with contraception, keeping safe and understanding about relationships. My dad was a traveller and my social worker and her manager wanted to tell my dad about what had happened. My mum knew he would go mad and find the boys and probably beat them up. I lived with my mum then and sometimes saw my dad. The outreach nurse talked to the social worker as she had met my dad and explained that this was true and it would put my mum and me at risk. I was excluded from school and went to another school and then excluded from that school. So my mum decided to homeschool me, which really didn't happen because she wasn't at home most of the time. My social worker left and then I had another social worker. When I was 14, I met a group of girls and went on the train and met a 32-year-old man at his house. We met him on Facebook. When I didn't come home that night, my mum reported me missing as the police came to the man's house and arrested him. They took me and my friends away. I was then labelled as being sexually exploited. I didn't know what this meant. He went to prison. The new social worker came to see me with another worker. She wanted to work with me on my behaviour and changing what I do. I didn't like her much because she treated me like a baby. She went off sick, so I only saw her twice. I saw a counsellor who kept asking me how I felt about what happened to me, but I felt that nothing had happened and I was fine. The outreach nurse kept seeing me every 3 months for my contraceptive injection. She always came to my house and saw my mum at the same time. My mum really liked her because she wasn't stuck up and didn't talk posh. She never made us feel uncomfortable and explained things to me and my mum. She has been the only person who has told us the truth. She has always let me know before she speaks to the social worker and tells me what she's going to say about me. The outreach nurse is the only person who's kept seeing me and working with me. I then moved away, and where I was living didn't have nurses that come to your house, so didn't use contraception. I became pregnant at 17, but the social was back on my case. I had my baby early and was moved to a big posh house with a foster carer who was looking after me and my baby. I had the outreach's number still and got my foster carer to call her and tell her I was back in Worcester. The nurse came to see me and fitted a contraceptive implant in my arm. She explained to me after talking to the social worker that I was being supported to look after my baby boy and that because he was on a child protection plan, they needed to make sure I could care for him. I ran away from the foster carers and my baby was eventually adopted. I hated everyone. And most of all, I hated myself. I didn't see any professionals after that. The GP removed my implant. I drank alcohol, took drugs and lived wherever I could. I tried to keep contact visits with my baby, but I couldn't remember the days and times. I knew what they thought of me and what they didn't have to say anything. I could read their faces. I had 2 more babies after that, all taken into care. Then 2 years ago, I was offered a pause worker, a new thing that was happening, and it meant that girls like me could get help. You had to have babies in care or adopted, and you had to agree to use contraception. That's what pause means. My worker phoned the sexual health clinic and took me for an appointment. I was scared, and I was told to bring a urine sample to check I wasn't pregnant. I took Red Bull in a glass jar, and they couldn't continue because I couldn't give them a sample. I didn't like the clinic. There are too many doctors in masks and they made me wait. I went home. I had my 4th baby boy on the sofa at home 2 days later. The paramedics came and he was also removed from me. Yes, I had another baby. My pause worker contacted the outreach team at Sexual Health and an outreach nurse came to see me. It was the same nurse from all those years ago. I couldn't believe it. She was the same and remembered me and my first baby. She remembered loads about me and what surprised me because she is way older now. She remembered my mum and my brothers. I talked to her and I told her that I was scared when I was pregnant before. I didn't want anyone to know because I wanted to keep him this time. That is why I agreed to work with pause. I didn't want to tell anyone. She said it was okay and she understood. She asked me how I was and that she would help me if I didn't want to be pregnant. She fitted a contraceptive implant and that's where I am today. I have come to the end of my pause programme and I am in a good place. My boys have all been adopted and I am hoping that when they are older they will want to see me. I think the outreach nurse job is good and everyone should have an outreach nurse. The nurse continues to support me to help me to keep my implant in. I can text her and she gets back to me. I said to the nurse that I remember her saying that I can always get in touch, and she has been true to her word. And that's the patient story.
Thank you very much, Jackie. And as you say, very powerful stuff over a period of years that our services have retained that relationship. Can I ask colleagues now any questions that point of clarification? And first up, I've got Janet. Thank you, Janet.
Yeah, thank you, Mark, and thank you, Jackie. Yeah, I agree, that was very powerful. And I think it's something that probably a lot of us haven't really got any experience of. So it's really, I think what you've done, and obviously you're reading things out, I think you've really given the patient voice, because I can imagine somebody sitting and actually saying that to us. So thank you for that. My immediate thought is that this seems very dependent on the individual caseworker that was working with the patient, and very personal relationship, and I suppose it was a reflection on that, and on how do we replicate that sort of relationship, or how do you and your team replicate that sort of relationship with the people that you're working with, because it does seem, as I say, to be a very personal thing. And then my second question was actually around support, because I think if I was in that person's position, I would feel that I needed quite a lot of support to work with that young person. So what sort of support do you have in your team for the workers?
So thanks for that, Janet. That's a really good question, actually. We do have lots of support within safeguarding supervision, which I do all the safeguarding supervision within our team. However, we've been trying for a long time to get some specialist emotional resilience supervision. In our team, especially now, we've got some new nurses that have come through into our team, and it is a totally different way of working. So on the box, it seems that we deliver sexual health care, contraception and STI screening and treatment. We sort of take the clinic to the people. We're trying to engage with them. And myself and another colleague, one of our nurses, have been doing this for a long time. And it's really getting that support in place, which I'm trying really hard to do for our new nurses, because, they potentially could be doing this for a long time, and it does take its toll. I will say for our team, the good point about the outreach team is that our sickness rate is very low. We hardly any sick. So we talk about burnout, but there doesn't seem to be burnout in our team. And the question I always look to for that is, I think it's because a certain type of person does the job that we do. It's not for everybody. Even though they're specialist clinical nurses, they're also very special people as well. They're the nurses and the support staff that you would want to look after you. So I think that's what's so positive about it. I mean, they might say something different if you ask them, but the support is there. It's about the support. Yeah, and that's all I can say really about that. But yeah, it's really important, and we're sort of getting more aware of that, of the importance of looking after our teams and our staff, aren't we now? So we're nearly getting there with the specialist support.
Thank you. If we move on now to Martin, then Tessa, please.
Yeah, thank you very much, Jackie. And I just wondered, through the story, the how we work with partners, and that I was taken by the difference in approach between the social care and the nursing care. And is that systemic, or is that down to the individuals, or is it, how do we work in partnership effectively, and is that something we need to focus on more in terms of how we develop those relationships?
Yeah, I think I can only speak for my team. We've got a really good relationship with partner agencies, as well as our own agencies within our trust, school health, public health, nursing, midwives, social workers. It sometimes is a real challenge because not everyone understands what we do, and unless you actually do the work, it's very difficult to, help people understand what we actually do. So yeah, it is a bit of a challenge, but I think the partner agency work is good. I think that it probably needs to be joined up better across the trust, because there's some really good organisations and agencies out there, and we just tumble across them really. We don't always know they're there. And it's just almost like we need a one-stop shop to know who these people are working, especially for our young people, because our young people are our future, and we haven't actually got it quite right yet, and we probably never will, if we're honest. But there was a lot of stuff mental health wise going on. It's just knowing about it and tapping in and getting them to the right person at the right time. And our vulnerable patients want to see somebody when they want to see them. They don't want to see them 2 days, 2 weeks, 3 months down the line. Their problem is, has impact on them at that time.
Yeah.
Does that sort of answer your question, Martin?
Yeah, thank you. And I think that how do we develop that one-stop shop is a challenge we've got across all our services. So absolutely agree. Yeah.
Yeah, I'll just say about that is we just have to try it. We just have to do it. We need a more of a can-do attitude. So let's try it, and see if it works. If it doesn't work, our patients and our service users will tell us it doesn't work, and then we need to be adaptable and we need to be more patient-led, don't we, rather than try to get our patients to fit into us, which is what my team do. We sort of fit into our patients.
And I guess the follow-on for that is do you feel empowered to have a go and try it, or do you feel blockages in the way?
Absolutely. Our team is very, we're supported with that as well.
Thank you.
Jackie, my question picks up from Martin's really. Sadly, I am familiar with this story from my clinical background and management interface with sexual health. So shocking as it is, it's not uncommon. Obviously, Libby's story is of a very chaotic lifestyle. And I just wondered what your thoughts were really on what could have been done sooner to actually prevent her having to get to 4 pregnancies before she got to pause. And then also, are there agencies helping her around the drug and alcohol issues that she's had, so that she is getting help to come out of that chaotic lifestyle? But particularly, do you think any earlier intervention services or any more joined up working earlier on in her life would have helped prevent some of the pregnancies?
Yeah, thanks, Tessa. The answer to that is yes, obviously, but it's where does that intervention start? And also, she chose to actually take herself out of the system. And I say we as in the broader we, I mean we as in everything, children's services, social care, everything else. And sometimes our vulnerable patients and service users don't actually realise themselves. It's sort of the Nanny McPhee thing, isn't it? So she had quite a lot of interventions, Libby, early on, all the way through her life. She was known to children's services from a long time. It's all about that intervention, isn't it? Even before a baby's born. And that's really challenging and hard work. And sometimes we always look at the stories that aren't always so great, rather than the stories where we made a difference. And we don't know whether it was just us that made that difference or they empowered themselves to make a difference. It's a real difficult one to call, isn't it? But the answer is yes, of course. Intervention as early as whatever would have been the answer. However, maybe not. We don't always know, do we?
I think you can definitely say you're making a difference. Your team are making a difference in partnership with her. And that's what struck me really about what you said. You were working with her, not against her, whereas she appeared to feel that other people were against her and your service wasn't. And that's a great credit to you all. So well done.
Thank you, Tessa.
Thank you, Tessa.
Jamie and then Steve.
Hi, Jackie. Thanks very much for telling us Libby's story. That was very moving. Some of the things I wanted to ask about, Tessa and Martin have already covered, but I did just want to ask a factual point really about PAWS, because I'm not very familiar with what they do. What's the coverage like in Herefordshire and Worcestershire, and what's their profile? How well known are they by the agencies involved that would be referring people like Libby to them?
Yeah, so PAWS was a new intervention probably 2 years ago now, and Sharon will send you all the updates for PAWS. And we became involved in sexual health, not just sexual health outreach, the wider sexual health service as well, because they came to us first. So they're actually funded, they're employed by local authority, even though it's sort of charity based. I might be talking out of turn here. Tracy might be able to back me up with this one. And they work with any women who have had 2 or more children removed in permanent care. And they sort of got their cohort of women from children's services, even though they can only take a small percentage of those women because it's intense work. And like Tessa was asking about the mental health and alcohol and drug use, they work intensely with those women and pull in all the services that need to support those women. However, the women need to make that choice and decide to work with the programme. And part of the agreement of the programme is that they have a pause in pregnancy. That's what it means, pause. So they need to have some contraception or long-acting reversible contraception. So that's where sexual health worked hand in hand with pause. So sexual health sit on the strategy board meetings for pause as well, so we can input and vice versa. But from a hands-on point of view with pause, it meant that those women are so vulnerable, probably the most vulnerable women we've ever seen, that sometimes just can't get out of bed of a morning, that just have an appointment and then can't come to their appointment, or they come and then they run off because they're so scared. It's all about the trauma they've experienced. So they work with them in a very trauma-focused way, and their outcomes have been very good, even though it's very small numbers. It's good, and they're on to cohort 2 now. So they've worked with those women for 2 years. They then get a support advisor at the end of it, and then it continues again.
And that service is available throughout Worcestershire, is it?
Yeah.
What about Herefordshire? Do you know if it's available there?
Pause is just Worcestershire at the moment. Am I right, Tracy? I think it's just Worcestershire at the moment.
Yeah, there's lots of places across the country, Jamie, that it covers, but yeah, not Herefordshire on the list at the moment, just Worcestershire. I think the pilot of it was set up in 2013 for pause, and like Jackie said, we've come into contact with it in the last couple of years, and the pause practitioners normally work with about 6 to 8 women that have to engage in a 16-week programme so that they can build that relationship up with their pause practitioner as well. I'm not sure, maybe it's something we can raise at the next pause board actually, as to whether if there's Herefordshire on the list and they're looking to expand, but it is just Worcestershire at the moment.
Thanks, Jackie. And we'll go over to Steve before I round this up. Steve.
Yeah, I think it's a very quick question, but probably not an easy answer in truth. I was trying to get a sense of the size of the challenge in terms of numbers of folks that might benefit from this service. I guess there's some folks you will never know about as such, but do we have a sort of sense of the sort of pyramid of need, as it were, and whether fundamentally we've got enough of those trained individuals that actually can meet that kind of challenge?
Hi, Steve. Do you mean within the pause project, or do you mean within my team, Sexual Health Outreach?
I get this sort of sense that particularly the story that was told, which was wonderfully told, by the way, Jackie, was there's a sort of a need there that you can intervene at various stages, and you can prevent that getting to the sort of ultimate outcome that this particular individual got to. But I don't get a sense of, are we dealing with 50,000 potential individuals that could get to that kind of scenario? Are we talking about 10, or are we talking? I just don't get a sense of the challenge here.
So relating to pause, the women in Worcestershire that were known in the first cohort, there was 150 women that met that criteria within Worcestershire, but pause could only take a small proportion of those women. So I think they had to choose 25 or 30 from a list, which doesn't sound great, I know, but that's how it had to work. So it was a pilot to start with. Relating to us within Sexual Health Outreach, our caseload between my team is about 800, but these aren't all these women. This is, the sort of the most vulnerable women that we would work with. We work with boys as well, girls, boys, anybody up to any age. So we might get somebody that's vulnerable because, they're in a school and they can't access a service, or they can't tell somebody. So we would see them as part of teenage pregnancy prevention and all the sexual health care that goes with that. or the other extreme is to, you know, what we've just discussed today, where they need more intervention. We have a really good case closure and supervision process, which I manage. Otherwise, we just end up seeing everybody, and it's what that definition of vulnerable is. You become vulnerable because you can't access a service or a health service, you can't see your GP, and they become vulnerable. So have to be quite clear of our referral criteria, because with the way everything's pulled today with capacity, we get thrown a lot of referrals that actually aren't relevant for us.
Sure. Martin, Mark, if I may, I was just going to ask, well, it's not, it's a comment really. You could see that early intervention could prevent, you know, an absolutely extraordinary level of future intervention, more costly, more traumatic, etc. I didn't know whether there's been any research done on, you know, cases of the type that we've just heard about, whereby if you put more effort at the front door, as it were, you would make so much difference in terms of ultimate outcomes and you know, less institutional and NHS social care intervention further down the line, because that feels to me the kind of work that an ICS should be all about. You know, if we did this here, what would it do there? And I don't know whether any work of that type has ever been done.
Lots of work, Steve, lots of work. So going back to sort of even before pregnancy, so it starts with our young people, doesn't it? So it starts with their education of our young people, and young people being able to access services openly and honestly. And it's also that pace of changing with the times, because what young people wanted 10, 15, even probably 5 years ago is different today. And it's all about knowing your communities and who you work with in the communities and all working together. But I think we'll probably be saying the same, if we're honest, we'll probably be saying the same thing in another 10 years' time, because a lot of it is changing cultures and, you know, aspirations for people as well. You know, we've got a cohort of young people in Worcestershire that aren't in any education, and that should be something that we're all shouting about. Why are they not in education? And, you know, that's the sort of thing, but we need to be looking wider and working, you know, all together with local authority and meeting the needs of our communities. So, yeah, everyone knows it starts early. I mean, Tessa, health visitor experience and midwifery experience, we know that it's how, the question is, how do we do it?
It just feels as if we spend more money on scraping the burnt toast rather than dealing with why the toast was burnt in the first place is the point, I suppose.
Yeah. And I think more patient journeys and stories, because actually what could we have done differently to help somebody like Libby to change anything? And actually, would it have changed anything? It's all retrospective, isn't it? Looking back yeah, real challenge.
Thank you.
Thank you, Steve, and thank you, Jackie, Tracy. There's a couple of comments I would make to conclude, and the word vulnerable has been used numerous times, and rightly so. And I think what we've just heard is how we deal with some of the most vulnerable people in our society. And the more vulnerable people are, we know, the more difficult and the more complex it can be to deal with these people, because the problems that our vulnerable citizens have tend to be complex and a multitude of things, not just one element of their lives. I had the privilege of visiting the outreach team, what was it, about 6 months ago now, and a couple of things still stick with me to this day, which is somebody, I think Martin asked, are they empowered? Did they feel empowered to make some changes? Well, the people that I met, and some of them are very, very experienced, they certainly conveyed to me they're empowered to do whatever they thought was the right thing, to be honest. They were a very forceful, fantastic group of people I met, and I came away thinking how not only how great the service was, but how, I think somebody described in the chat, how they delivered it. And they were so passionate about what they did. And whilst I was with them, there were phone calls coming into mobiles because of that exact thing. Here's my number. If you want anything, give me a ring. And it was sincerely meant and it was sincerely used. The other thing I witnessed was an MDT meeting. I was privileged to be invited to come and listen, and this really was agencies across the whole of the public sector, from the judicial system, police, social services, education. And the one thing I do remember is that the vulnerable individual that happened to be a young man on that case, a young boy, there were only one agency that seemed to have the trust of this individual, and it was the sexual health nurses, and to a same extent the school nursing team. Everyone else seemed to have from the young person's perspective, an agenda. And I think that one-stop shop was being provided, even though it probably wasn't on the label. The sexual health and school nursing team were providing just about everything to these young people. Even if it wasn't on the label of their badge that they were sexual health or school nurse, they were doing just about everything they could to look after these vulnerable people. And it was so impressive, Jackie, Tracy. If you could, I did pass it on at the time, but I remember to this day how impressive the team were. So if you could pass that on, and our thanks for the working in what you may think is a hidden way, and rightly so on occasions, but your work isn't hidden from board, it isn't hidden from your managers, and we very much thank you for the work that you do, and please pass that on to your teams, and thank you for coming along today.
Thank you, everybody.
Thank you,
Thanks,
everyone.
Jackie.
Have a
Thank
good
you.
meeting.
Thank you very much indeed. If we could move on now to the Chief Exec's report, Sarah.
Thank you. Morning, everyone. I just wanted to, before I go on to my report, just briefly pick up on urgent care. It is covered in the operational section of the agenda, but I'm also conscious Rob might have to dip out for certain escalation calls on urgent care when we get to that paper. So I thought it was worth a mention now. So Mark headlined it at the beginning of the meeting, but just to be clear that the urgent care pressures are one of our absolute key priority focus areas at the moment. The system is under huge levels of pressure, and our staff and staff across all of the partners across the system are working really, really hard. We know that it's an industrial action day today for the ambulance service, which means that there's been additional planning going on yesterday to make sure that we're prepared and able to respond. But the system is extremely tight, and there are a number of risks around that the board may want to consider at some point. Just to say that our UCR to our response has been doing an absolutely amazing job. They saw over 1,200 referrals in December, which was similar to October, dipped a little bit in November, but they're doing a fantastic job, and they are now directly every day on a number of occasions pulling from the ambulance stack. So even though we're getting a lot of direct referrals now from the ambulance service, from 111, 999 and the clinical validation service, we also look at the ambulance queue and also see if we can pull anybody else out that we think we could support at home. So they are doing an amazing job, and it's worth just reminding us of that, because a lot of the discussion is often about bed availability, but the community response has been superb. All community hospital beds are open and occupied, as you know, and we are running, depending on the day you ask, between 20 and 24 extra beds, which we can escalate up to 24 if there's a critical incident level need of concern. The workforce pressures are, however, huge, so our ability to find staff to manage and support and oversee the extra capacity is now becoming a real challenge across the system. We're relentlessly focusing on discharge, and we're also working with social care around the options for spot purchase. We are now being asked to open even more capacity, and region have asked that all capacity across every system is fully open. So we're now looking at options which we wouldn't previously consider, and we are very concerned about our ability to staff. But clearly, given the level of concern in the system, we're exploring these, and they include an area in the acute hospital that could be used for inpatient care, and they include the options around Harvington, which, as you know, is one of our wards at Kidderminster, which is currently being used by an acute service that's decanted for building work in the acute. So increasing risk level, I guess, and increasing pressure, but we are doing everything we can. I don't know, given I think Rob's got to go at 10 marks, do you want me just to bring Rob in for any additional comments now or at the end of my report?
I think, as you've mentioned it now, Sarah, and bearing in mind Rob could disappear anytime. Yeah, please do so, Rob. This is the
okay,
major
Rob,
thing that's impacted upon us. So yeah, please come in.
Yeah, thank you, Sarah. Thank you, Mark. And yeah, I'm going to have to go about 5 to 10 for the next meeting. I've got a series of meetings this morning around the ambulance strike. So as Sarah has said, significant pressure in the system, huge amount of regional and national scrutiny, particularly due to what's being demonstrated through ambulance waits outside A&E, and I'm sure everybody on the meeting today is familiar with the detail associated with that. As Sarah said, brilliant performance by UCR, the Urgent Community Response Service that sits within neighbourhood teams. Today, as part of the ambulance strike and previous ambulance strike, we're really stepping up to the plate further with UCR. So there's some really exciting developments, particularly in our close working relationship with WMAS, the ambulance service, where we're now directly able to access their call stack, if you like, their waiting list, people that are waiting for ambulances to attend or need triage and validation by the ambulance service. And we're actively validating and pulling cases off their waiting list and for a neighbourhood team community response. We're also directly in reaching today, as part of the ambulance strike actions, directly in reaching into the acute trust to A&E and the same day emergency care facility. With regards to beds, as Sarah has said, we've over the Christmas period, or actually I should say since July, we increased our bed capacity, what we've described as surge beds, across a number of our sites, and we further increased that leading up to Christmas. The system has been on what's described as level 4, its highest operational activity level, the whole system. We tipped into critical incident leading up to Christmas. We opened 2 additional surge beds down at Evesham. And throughout the Christmas period, on top of significant staff sickness, we've operated at kind of level 4, close to tipping into critical incident. Myself, Natalie, John and Sarah have been involved in a number of system and regional calls kind of over the course, particularly over the last 48 hours, in preparation for the ambulance strike. And the ask of us, particularly today, but yesterday leading into the strike and tomorrow to support recovery, is to continue with that enhanced UCR offer, absolutely maximising our flow into and out of community hospitals, maxing out on our bed capacity and doing all that we can to support system partners. Extremely challenging, but I think it's fair to say that frontline clinicians, nurses, therapists, support workers, the leaders of those groups have absolutely pulled together to try and support the system cause and the pressures that are being experienced currently.
Janet, do you have a question about the UCR?
Sorry, yes, I did. Sorry, I thought Steve was first, but I'll just jump in.
Oh, sorry, I didn't see Steve. Yeah.
So it's okay, don't worry. That's why I was waiting. So yeah, my question is about sustainability, because it just seems to me as though we cannot carry on like this. At the back of my mind, I've obviously got safety, clinical safety, and I know it's very nuanced, but it's so really I want reassurance about that we are delivering safe care, but also how can we sustain this? Because it doesn't seem any sign of it ending soon. There doesn't feel to me as though there's any, where's the light at the end of the tunnel?
I'm happy to respond to that initially. Natalie, you might want to come in because you work closely with ops teams with regards to the impact on quality and sustainability. Janet, I think you're absolutely right. We were asked at the latter part of last week to support the opening of additional capacity. Myself, Sarah, Natalie and John met Monday evening to kind of analyse the impact of that, and we felt that given current circumstances, particularly with staff sickness and vacancies and our reliance on temporary staffing, including agency staffing, we weren't able to support that model currently. There was a push from the system to get these beds open in preparation for the ambulance strike today. We've resisted that. We don't feel it's appropriate, it's safe, and that we could manage to staff that safely, whether that's through further diluting our substantive staff or bringing in additional agency staff. What we are trying to do is work with partners, particularly the ICB, with regards to additional clinical support from some of those corporate services. And there's something called the reservist list. There are nurses that have been identified as recently as yesterday that may be able to come on board and support us further. But on the current establishments, we can't support additional capacity demands currently. Natalie, do you want to add to that? Because I know that you've been very involved in those discussions.
Yeah, and thanks, Rob, and very eloquently described. So we're exploring those additional options. As you said, Janet, sustainability is a real worry, and I think in all reality, we're expecting this pressure now to last until the end of March. That's the kind of time scale that we're really thinking of. So we're scoping that additional workforce to see what that could give us. We are starting a piece of work. We met this morning with the team to think through about how we can break down our safer staffing data to give us some more detail so we can really get to grip with where our pinch points and our high risk points are. We'll also need to relook at our red flags and our metrics that we probably will now need to monitor more closely over the next couple of months. So we review them monthly at the moment. We'll probably need to do that much more closely to make sure that we're really on top of that from a perspective of early warning indicators that things are concerning us. And then again, it's really initiating these conversations, isn't it? What can we do very practically to support those teams on a day-to-day basis? I'm not talking about the health and wellbeing hub. I'm talking about those really practical, low-level interventions that will enable staff to get through the next couple of weeks, that shift, that day, and those very simple things that we know really work well about just basic human contact and refreshments, those things. So we're really looking at that. But I think it's a very high-risk period we're entering.
Steve.
Mark, my question was similar but slightly different in that how you objectively decide that one area of risk in the system is greater or less than another area. It feels as if you could get all sorts of voices being aired that push you down a route that without consideration to that level of risk and whether it's greater or less. And I would to get some assurance around the question that Janet asked, is there a system that empirically judges that, or is it not quite as objective?
So I think that,
yeah, please.
Lovely. So I think, Steve, it's a really important question, isn't it? And we've been having conversations with the ICB around, we have a very clear governance process internally, how we do quality impact assessments that enable us to really identify the risks, balance the risks out and make a clinically led decision about whether something should continue or not continue. We're not at that sophisticated level within the ICB yet, but we're having those conversations about how do we do that. In the interim, we've just set up a chief nursing group, which is now meeting daily, so we can absolutely identify those risks from a clinically led perspective across the entire breadth of our provider organisation, so that we're not forgetting things like the level 4 risk in mental health, and we're not just focusing on urgent and acute care as well, but we are taking into account the impact this has on our community hospitals. That so far, I have to say, is a really positive, and it definitely feels that we're all on the same page and trying to work together with that. And we have a clinical professionals group across the system as well. So it's how we utilise those now to really feed into those system meetings we have to make sure the whole risk is being considered. But it's not sophisticated in its development yet.
Okay, thank you.
If I may, could I just extend that question, Natalie? Can you give us some assurance that the risk includes those people that haven't yet reached the NHS, i.e. the person that's called the ambulance but can't get an ambulance for X amount of hours or minutes or whatever it is? Is that risk part of your discussions?
Yeah, those risks actually are really actively discussed in the current system conversations, and that certainly drives a lot of the concern around that front door around every single silver or gold call. Those risks are presented. This is how many people we have waiting for category 1, category 2, category 3 for ambulance calls. So we know exactly how many people are waiting, the length of time. That's when our urgent community response team, again, are really great at, we push that every meeting around, are you utilising them? And you making sure that we are pulling everybody off that ambulance stack that we can, and that we're aware of those people who are left waiting for protracted times. So yeah, that risk's really well articulated.
Thank you, Natalie. And before I pass back to Sarah, just some stats actually that Sarah gave to me and briefed me on is during December, that taking from the stack and other areas of WMAS prevented 9 ambulances a day as an average across December having to attend the ED. Bearing in mind, 9 ambulances out of what is probably around 100 a day. That UCR team, just through that activity, is reducing 8 to 10%. So it's a tremendous success, although it doesn't help those that aren't receiving an ambulance. It's certainly making things better. Back to you, Sarah.
Thanks, Mark, and thank you for letting us do that first so that Rob could contribute. Really appreciated. So just briefly through my report, hopefully quite a bit of my report is about national and regional actions and publications. So I'm sure you've all read that, so I'll just pull out a few. The first one of note I just wanted to pull out was the planning guidance, which, as you know, came out on the Friday before Christmas. That has now been published, and we're incrementally getting all the technical guidance that sits behind it. You'll see in the report it outlines the 3 key tasks for the NHS over the coming year: recovering our core services and productivity, making progress in delivering the key ambitions of the long-term plan, and continuing to transform the NHS for the future. It's fair to say quite a lot of the existing priorities roll over into next year. They've tried nationally not to give us a lot of new priorities, but to continue with the ones we've already got and strengthen them, which is really helpful. Rob's just received some of the financial detail. I think it was yesterday or the day before. So I think in due course we'll need to brief the board not only on what this means in our planning processes, which we will build the guidance now into the planning process that's already underway, led by Sue's team, but also I'm sure we'll need to discuss the financial implications of some of the technical guidance in due course as a board. I've also outlined the CQC new quality statements, and I know in a development session we're planning to have a further discussion about that so that the board are really clear how the CQC approach is changing. So that's in the report. I think we've previously mentioned the patient safety response framework and the CQC matters. Just in light of the urgent care conversation, just on page 6 of the report, 40 of Diligent, you'll also see a comment about the winter health letters, the mental health letter about winter, sorry. So there was a national letter sent out about priorities for action over winter. There's now an explicit one for mental health, which I've outlined here. All of these actions are being progressed, but one of the key things you might want to pick up later, perhaps when we get to the mental health collab report, is that part of this is about strengthening the ambulance response to mental health. WMAS already have mental health practitioners in their clinical triage and control centre. This is now about mental health skills and expertise actually on ambulances, and how that might work in a rural community is one of the key areas of debate, but might come up later. We've touched on the industrial action today from the ambulance service, and as you'll know, since we last met as a board, the RCN, we were involved in the RCN industrial action for 2 days in December. I would say that was managed very well by staff, all of whom were quite proactive about declaring their choice around whether to take industrial action or not, and staff notified us in advance so that we could plan effectively and apply for derogations where they were required. As you know, I've mentioned it before, it was very disappointing that nationally mental health derogations weren't automatic in the same way as physical health, but actually we managed that locally with a successful conclusion, and there was and basically tried to limit the impact on the day, but staff were very supportive of that. I've also touched on that page on the supporting children and young people with mental health needs, which is linked to the winter pressure letter I've just met. But this is quite an important area, because you'll recall that historically there have been a number of issues about children who are waiting for a tier 4 CAMHS bed, who sometimes are cared for in an acute paediatric setting while they wait for a transfer to a permanent appropriate placement. So this is national guidance on that issue, which I think is really welcome. Just moving on then. Just on the bottom of page 8, just to note that you'll be aware that Patricia Hewitt, the Right Honourable Patricia Hewitt, is doing a review of ICSs. My understanding is this is not about changing the structure proposed. It's about how we can maximise the benefit of ICSs, and I know a number of board members have been involved in various national or local conversations about this, so it's one for us to be aware of and to input in as appropriate. Clearly, some of the key issues for debate are things like accountability, about making sure as a board we have accountability for our own organisation as well as an accountability for the system. How does that work? What does that mean? Are we all clear? So there's a lot of conversations going on around this at the moment, and we're feeding into the consultation process. You'll also note on page 9 just the new report on monitoring the Mental Health Act, which will go through the legislation committee. In terms of our own integrated care system, we are expecting the CQC to visit us or some of our services. We're not quite sure what that will look like yet, but it's part of a system review on urgent and emergency care. They visited both of the emergency departments at Wye Valley and Worcester Acute before Christmas. We also know they've had conversations with the ambulance service. We're not quite sure when that will come to the trust, but we are expecting them to involve us in that review in due course. Just on the CQC as well, for completeness, we still haven't heard from the CQC with regards to the final report on Hillcrest, but as you know, the action plan is complete and the transformation programme is ongoing. You'll note that the Worcestershire Joint Local Health and Wellbeing Strategy has been published. We are planning a board development session to go through that with public health colleagues with the board in more detail so that you can see what the current messages are from that. But just to let you know, it's been published if you'd like to review it. In terms of trust issues, you'll know that we've got ongoing issues with care notes. I do want to explicitly record this at the public board meeting, though, around the decision on the 8th of December. You'll see in my report we referred to at the last board, we knew that a decision would have to be made about whether care notes was technically safe to allow us to start reconnecting clinical staff and inputting patient data. The board delegated that decision at the last meeting to a core group, Mark, Julie, myself, David and John. We met on the 8th of December, and as you'll know from email communication to the board, that group formally agreed that it was safe to proceed and start to restore services and our patient data onto the system. So David will cover that, no doubt, in more detail in board conversations, but just to formally note that that decision was made on the 8th of December, and the process to reconnect teams starts this week. I've mentioned Hillcrest. The only other things I just wanted to pull out is just to bring to your attention that on the 22nd of November, the new Jenny Lind ward opened. This is part of our dormitory project, and it's great to see a second ward opened. As you know, Holt opened in the last few months, now Jenny Lind, so really making good progress on that project. And just to formally note that Cheryl Miller, Associate Ned, as you know, decided to stand down from her role with effect from the 31st of December. And we all know that Cheryl made a significant contribution in the short time she was with us, which I want to note and thank her for doing that. So thank you, Mark. Happy to take questions.
Thank you, Sarah. Jamie.
Thanks. Just a comment and a question. The comment, I just thought that the overall trust response to the Industrial Day of Action was commendable. Sarah's mentioned the response of staff, but I also think the management of the day seems to have worked well. The staff who gave advance notice, as well as the staff who continued to work, and I just think overall it was handled as well as it could be in the circumstances. I'd just like to recognise that. The question on a completely different matter, Sarah, and we've mentioned this before. When there's something big about Worcestershire, such as a health and wellbeing strategy, yep, how do we cover that in a way that we also give similar attention, hopefully simultaneously, to Herefordshire? Otherwise, we end up with a bit of a two-tier approach to the strategic planning of what we do. Can we do them at the same time with both lots of public health staff, for example?
Potentially, yes, but they're unfortunately at the moment not working on the same timeline. So Worcestershire's work on the strategy was ahead of Herefordshire. That's just timing on previous strategies, etc. So they will come together in the integrated care partnership strategy, which will come to board in March, hopefully in March, for final sign off. Obviously, it's going to be signed off by the partnership, but all of the work of the health and wellbeing board strategies will come together then. But at the moment, they're on slightly different timelines. So I don't know, Sue, if you want to comment about when we'll be able to bring Hereford, but it should be at the next meeting, shouldn't it? Certainly in the next 2 meetings.
Yes, you say Worcestershire's was signed off at back end of last year, and Herefordshire's is currently out for consultation, due to come through, I think, publication 1st of April, but the headlines now are starting to come through from the work that they're undertaking. Should all come into the integrated care strategy, as you say, Sarah, so that's the 2-county view. When now, Jamie, we're trying to get the needs assessments onto the same timeline, so we end up being much more joined up as we move on through a few years. So yes, the next meeting we should have a much more clearer view across the 2 counties.
Yeah, thanks, Sue.
And to conclude, Tessa.
Thanks, Mark. Sarah, I was interested in the autism sensory friendly report, and it just struck me that whilst, yes, it's logical to share that with LD and mental health services, it wouldn't be a bad thing to share it more widely across the organisation, because autistic people can access all of our services, for example, sexual health that we've heard from this morning, and actually all services having a mindset to think, okay, we won't have a full sensory friendly room, for example, but how can we make our environment more sensory friendly, be more sensory aware, to help people with autism come into our services. So I just wondered if we could expand the sharing of that report, really.
Yeah, totally agreed, Tessa, and that's the approach we're taking. You might recall Kathy Hankins came to a board development session and mentioned this. So Phil, who's on the call as well, has been following this up for me, because it's about, we should be a role model, shouldn't we? We should be looking at this across all of our services. So it's, what does that mean? It's quite complex and quite extensive in terms of the possibilities, but we're starting to look with estates at what are some of the early things we could do across all of our sites to move this project forward. So absolutely agree. Thank you. Can't hear you, Mark. I think you might be talking on mute. Sorry.
I was indeed. Thank you, Sarah. Just to remind everybody, if you've not looked at the comments, that both public health teams from Worcestershire and Herefordshire are involved in our development session in February, so we'll have input from both sides of the Malvern Hills.
Thank you.
Okay, thank you, Sarah. There was a lot in there, but a number of those things in your report actually come out in other people's reports as we go down through the agenda today. Thank you. So if we can note that report, and also the decision taken, delegated decision taken on the 8th of December around care notes. Thank you. If we can move now on to item number 10, which is the board assurance framework and high level risk register, which we have at the beginning, at every meeting at the beginning, before we move then on to our committee reports. Jill, would you like to bring to attention anything that's new in the BAF, please?
Yeah, I think certainly from the issues that have already been discussed at the meeting, we perhaps need to review again, and I know we've talked about it before, the prominence of urgent care across our board assurance framework and more generally in our risk management, because we've certainly looked to include references to urgent care across a number of the very specific risks that are included on the board assurance framework, but it does feel as though we've shifted into perhaps a different sphere now, and a lot of effort from a lot of individuals is being dominated by the urgent care pressures. And I will pick up with executive colleagues as to whether actually we should explicitly have a freestanding risk on the BAF relating to this. That was just the first thing that I wanted to say. Obviously, we've got set out in the paper the freestanding risks that are on the board assurance framework, and we also have the highest level risks across the organisation, which, as you'll you won't be surprised to see cover issues relating to workforce, financial sustainability, the quality of care, the impact of the current care notes outage, and issues relating to the capital programme and eliminating dormitories are pretty much covering the highest level risks that we have. We continue to work with SDUs to support risk management throughout the organisation. And I think it's fair to say that in times of extreme operational pressure, it would be very easy for operational services to not focus as strongly on risk management, but I'm pleased to say that they continue to do that, because it is an important part of actually making sure that these highest level risks are fully controlled, mitigated, and we continue with those processes. In terms of the board assurance framework, we'd had some more extensive updates prior to the previous meeting, and there's just been a little bit of tidying up in terms of removal of some things that were a little bit out of date and adding new things on. But I think the most important issue that we're going to need to pick up going forward is about looking at urgent care and seeking to try and address that in terms of having it as a freestanding risk. Happy to take any questions.
Any questions from anybody at all? Jamie?
I'm sure if any teams did prioritise their approach to risk management, you'd be able to encourage them otherwise, Jill. My question was, it's more of a comment really. As we've said before, this format works well, the idea of bringing forward new risks to add to the current established high areas of risk. But I still feel it's slightly odd, this juxtaposition we've got between some very local specific risks and huge corporate areas of risk. Vacancies is an obvious point. So what we've got there is risks relating to services or indeed teams, and of course the overall risk to the trust around workforce challenges. I mean, maybe that's okay. It just still seems slightly odd to have both of them presented in the same place as if they're equivalent.
It's certainly an ongoing challenge, Jamie, and I certainly try and encourage people to look at whether, when we're talking about the higher level risks, actually areas that are very specific to an individual service shouldn't be scored in terms of the same magnitude of overall corporate risks. And that's part of my very regular support and challenge sessions to individual risk register owners to try and address that. And it is an ongoing challenge to try and ensure that we do have consistency about that.
Martin.
Thank you, Jill. And I realise it's a sort of ongoing process in terms of the development of the risk that we put an awful lot of effort into. It strikes me, and we've talked about it quite a lot this morning, both in relation to the patient story, but also into the community response and that responding to the urgent care crisis, that we've got to get more on the front foot with our mitigations. You talk about, there's a point in there about saying the urgent and emergency care response leads to, not knee-jerk, but reactions that haven't got an evidential base. And I think there's something we need to get into place about our mitigations, really building the evidence of early intervention, about the prevention that actually becomes systemic in the process, rather than always being, at the whim of what is happening in the UEC. And our role is different, and I think we're getting a bit dragged into that, rather than saying actually our job is to really build the evidence as to why an early intervention and care in the community, keeping people in their own homes in a managed way, is a much more effective risk mitigation than opening beds in corridors. And it's not a quick fix solution, but it's a strategic solution that must come through the BAF quite strongly.
Yeah, I certainly think that other colleagues on the call would recognise the attempts to consider, when the pressure is let's just open more beds, that actually there are alternative solutions, and I think that's part of the issues that Rob, Natalie and Sarah have been trying to pick up with colleagues, and so we just need to make sure that that is reflected, and that actually we start to build the evidence to try and respond to this knee-jerk, well, opening more beds is the answer, because yeah, it probably feels like we could keep opening beds and we'd still have the same problems. But I'm happy to pick that up with colleagues.
Okay, thank you. Before we move on, there's one specific risk that I wanted to seek some assurance on, which is probably Rob Mackey's territory, and that's risk number 1154 around facilities and estates. To start with, the likelihood is actually here. It's arrived, I think. So a likelihood of 4 is probably not correct. It's 5. It's here. The likelihood has arrived, I understand, because we struggle to recruit. But it would be easy in these difficult times of clinical challenges, UEC, the obvious one, to let go sight of the things that actually keep us moving day in, day out behind the scenes. And I feel this is one of them. Not only have they got the day-to-day maintenance, but they're also delivering on part of the delivery of huge, great programs of work across the mental health dormitories work. So I'd like to understand a bit more about what we're doing to try and mitigate the risk around our estates and facilities teams, so it doesn't get in a more parlous state than it's already in, please.
Yes, thanks, Mark. We're doing an awful lot, and I guess the reason we've got it here is over the past couple of months, things have been getting progressively worse. So it is patchy across the whole of the geography, where we have particular pinch points in terms of ability to recruit and retain staff, and we tend to go through periods when things pick up, and then we'll kind of stumble across something that causes particular problems. So we have been doing things. We've been trying bespoke recruitment approaches. We're very involved in the on-the-spot recruitment. There's an awful lot that's going on, but it is at the moment feeling incredibly stretched, and this is particularly around the domestic and support staff that work on wards in terms of patient-facing care, such as providing meals and so forth. So those are the things that we are particularly struggling on. It does tend to move around the county a little bit, or both counties a little bit, in terms of exactly where we are. But at the moment, it is feeling really difficult. Lots of things going on. So some of the things around time to hire and the process that we have to go through to get people to start. But we are struggling just in terms of, the overall perceived remuneration that folk can get for doing some of these really quite difficult but really important roles. So I haven't got an easy answer at the moment, Mark, but it's good to highlight that we focus on clinical areas, but these are some really important pressured areas as well.
Yeah, and I'm pleased to hear you say you're doing some things differently, because I was a little bit alarmed when we talk about NHS jobs in relation to some of these, the recruitment site in relation to some of these areas. For example, advertising an electrician on NHS jobs is akin to advertising a nurse on some electrical website. We need to be far more bespoke, and I'm sure that's what's happening. But some of the traditional methods of recruitment for these specialist roles are probably not required. Tessa.
Thanks, Mark. Just to say, the risk was discussed at Finance and Performance Committee, and then because Workforce Committee was the following week, we were able to pick it up at Workforce Committee and identify that we need to also think broader around the pinch point recruitment issues beyond safe staffing in clinical settings. So it is going to be monitored through the Workforce Committee.
Okay, thank you very much. Can we agree to the BAF as it stands at the moment? We'll revisit at the end of the meeting to see if there's anything needs to be added. Okay, thank you. Thumbs up. If we then move on to strategies and partnerships, and these are the major pieces of work across our trust that we as a board require to keep sort of updated on to make sure they're on track. Sue.
Yes, thanks, Mark. And it is the first report post our board discussion in October, where we wanted to really pull through early on in our agenda the key work programmes. You will recall there are a number of other priorities and work programmes. They will continue to run through the PMO and report to F&P. So these are the 6 areas that we agreed back in October, and you will see that we've given assurance level for each of these work programmes. So this is the first report, so I would like feedback on whether this is helping us navigate through our leaning into these programmes, which is what we felt we really wanted to pull through this report. So it picks up the progress against the key milestones for both November and December as an assurance level and a rationale for that assurance level, and then more importantly the actions required to reach the next level of assurance, so that we can all at board be really sighted on whether we're really utilising our governance structures and our capacity to enable ourselves to progress these key priority areas. The assurance in levels obviously reflects some of the status of the project. So just to pick up in particular priority 4, which is around improving the clinical model for adult mental health inpatient services. This is early work, so we're still very much pulling through the scope, bringing through that clinical leadership, setting out the vision, and working through the key metrics. Some of the other areas we've obviously been working on for some time. So priority number 5, which is the community mental health transformation. Obviously, this has been a couple of years now rolling through the organisation, and a lot of the challenges there, as we know, are due to workforce and different ways of needing to develop capacity. So I wasn't professing to go through any of the detailed priority points, but obviously this is the first cut of this report, and I guess for me really it's building up what else we think we want to see here. I know we talked about bringing through outcomes, more metrics, and then scoping out evaluation early for some of these key priorities. So that is also work in progress and will come through future reporting.
Thank you. Thanks, Sue. But Janet wishes to ask a question. Janet.
Yeah, it was a comment really, and that was, you asked about feedback on the report. I like the format you've used. I think what brought home to me was actually how much work is going on, which is absolutely phenomenal. So I suppose my question again, I'm fixed on sustainability at the moment, but it's actually, have we got the support in place to actually enable these programs to all run? Because I recognise that actually that's quite, project management is really important to get these things to deliver. So that was the question. And then the comment I got was actually on page 73 of Diligent. And this is just a bit of nitpicking really, but you've talked about Community Hospitals Development Programme, and there were 2 aspects. So you've picked out 2 assurance levels, one which is 7 and one which is 3, and then you've given the average as 5. And I was just going to comment that I don't actually think giving the average is helpful. I think it's better to leave it, because actually, putting something at 7 is good. We can think actually that's moving really well, but be more concerned about the one that's at 3, whereas this hides it. So that was a bit of feedback really, but I suppose my question is around actually, can we really deliver on this amount with everything else that's going on?
Yes, thanks, Janet. And just so the board are aware, as of the 1st of January, in my directorate, we've actually split off the Programme Management Office from business planning to make sure that we can have that dedicated capacity into both those areas. And the PMO actually has got additional folk coming on board. What we've also got is a number of programme management programme managers out in services or out in programmes. So we've got some dedicated resource for the workforce recruitment and retention work, for example. We are continually reviewing that, and I think the planning process gives us another opportunity to do so, as Sarah's flagged earlier. Thankfully, the planning guidance isn't layering in a load of new asks. It's very much building on what we're already doing, and it very much mirrors the report here. So I do believe at the moment we've got the capacity in the right place, but we are continually reviewing that, because actually it isn't just the programme management, of course, it's the operational capacity required to actually lead and deliver much of this change. And when we see delays delays, it's often due to that, as we described earlier, being pulled into different directions, whether that's managing industrial action, urgent care, etc. My team try and shore up as much of that as possible by doing the heavy lifting, doing much of the chasing, but of course that clinical operational leadership is key actually to taking the workforce with us. So those are the two dimensions for me that we keep under review. Thank you very much for the assurance, Average, Janet. I think this is the danger, isn't it, of trying to say, well, we think overall it looks like this. And I agree. I think, you know, the ACP delivery has been really, really strong, and we've seen great progress. Obviously, the outpatients relies on a different conversation with system partners, which is ongoing and changing again due to some of the financial regime. So I'll take that back and look to separate the two out again.
Thank you, Martin.
Yeah, thank you. I was going to echo Janet's comment in terms of actually it gives a much better flavour of what's going on. And I think the big thing for me from a board perspective, though, is being able to monitor progress. And when we've got actions required to meet the next level, I'd like to see what timescale we're expecting that to happen, so we can take a view on whether needs more impetus behind it and actually track progress against it. So. Yeah, I think it's a great new report. But if we can monitor the progress, I'd be happier.
Noted, Martin. I'll make sure that's included for future reporting.
Thanks, Martin. I had one comment along those lines too, which is when I read this, I found it great as an information, but what I want is information that may be needing board action. So I was hoping to see, you know, what's on time, what's on budget, or what's not on time, what's not on budget, and what are the problems? Because I couldn't quite deduce from the report whether loads of work going on, great, but is it the work that we wanted to happen at the right time? I couldn't quite tell whether that was the case. Because one of the things we want this report for, and I know it's developing, Sue, and it's great that we got to where we got to, is there actions for the board to take around this, or is everything okay? So I think probably just a bit more about the difficulties and the things that aren't on time and on budget, rather than what's gone well, so to speak. And I know it's a difficult balance. I'm not pretending it's anything other than difficult to balance those two things.
Yes, and as you say, it is an evolving report, but I think that would be really useful in terms of framing whether we're leaning into this sufficiently. Is there more board can do to move these programmes forward? So yes, take that forward going forward.
And finally, just one hopefully very simple question. Outpatients. It's only been going on for how many years? I don't know. You pick the number. Have we finally now got agreement from the acute trust? I think it was indicated in the report. Is it December or January? Sorry, December or November. There was going to be agreement. Have we reached that agreement?
I'm going to pass straight to Rob. We had a conversation around this just yesterday.
Yeah. Simple answer, no. But it's picked up as part of most of this is going back into a new regime, which is tariff, and I had a discussion with it's not the interim anymore, it's the substantive director of finance for the acute trust on Monday when we met. It's got to be part of the capacity plan they need to do around the plan. So they are looking at it, but we haven't got that completed at the moment.
Okay, I thought I was being a bit too optimistic in my own mind. Okay, thank you very much. Thank you for the report, Sue. This is exactly the sort of stuff we need to be kept aware of, and thank you for the comments from colleagues to try and continue to hone it. Can we note that report, please? Thank you. If we now move on to our committee reports, obviously we can take them all as read and just ask my non-executive colleagues to bring out the issues that they believe need to be brought to the attention of board. If we start first with Janet and quality and safety, please.
Yeah, thank you, Mark. Yeah, a number of these items are actually on the agenda elsewhere, but just picking out the assurance levels where we've scored relatively low. We've got CQC and Hillcrest. We've put that as a level 3, and we actually have an extraordinary Q&S meeting this afternoon to monitor progress on that. Mental health transformation update, and we scored as a level 2, and I think we're still struggling there with actually looking at trajectories for improvement, and we continue to push from the committee to actually understand what's happening, and so we're looking for more information in the next report to the next committee meeting. We're also looking at actually how we receive information back from external visits. Thematic review, we've scored that a level 3 because actually we need to have more focus on actually the more soft data, patient and carer experience. And so there's a workshop next year, well no, this year now, to actually look at a plan for that. Emergency planning, health and care core standards, that's on the agenda, but the reason we scored that level 2 is actually that the standards have changed at short notice, and we do have an action plan around that, but we still need to actually follow up on those actions, and I think that's a separate item on the agenda for the board anyway. Quality improvement, again, we feel that we still need to actually again get underneath this and understand what's actually happening as a result of the input. At the moment we're putting a lot of action into training people, but what we need as a committee to see the impact of that on services. So we're going to have a presentation in February to actually have a bit more of a discussion about that. We also looked at emerging risks, one of which we've actually talked about just now, which is around estates and facilities, and also the community paediatric service. And again, we're going to have a report of a risk summit, which will come to the committee in February. So quite a lot of works in progress, I think, is how I would report that. But I know we'll be talking about some of these issues further as the board meeting progresses. So thank you, Mark.
Okay, thank you, Janet. There's nobody showing, and as you say, we pick up much of these down through performance and other reports. So we'll move swiftly on to workforce and Tessa.
Thank you, Mark. Well, I'm going to do it even quicker than Janet, because actually I'd say all the areas that she's raised that we've looked at in detail from quality and safety, we've also looked at in detail from workforce, because they obviously go hand in glove. So Hillcrest, Evesham, estates and facilities. I think the bits that I just want to pick out that are different from the workforce committee's perspective, we're looking at a people experience dashboard. We saw a first draft of that and had discussions about it at Workforce Committee. We are hoping to get some of the freedom to speak up, soft intelligence and EDI softer intelligence data pulling through into that as well, to enhance the overall information that we're getting about our staff wellbeing, and the links that then would go back to patient safety. Freedom to speak up, we had a paper delivered to Workforce Committee. This is now being picked up outside of committee, and a way forward to look at the capacity within freedom to speak up, and indeed the systems and processes behind it to make sure that things are tied together, is being taken forward by Sarah and the exec team. So that's really positive news. And we had a very good update on the paediatric transformation, and looked at it from a workforce perspective. So I think that probably is enough of a summary.
Thank you, Tessa. Jamie's got a question.
Tessa, it's a really minor point, but I didn't quite understand why in this report, and unlike the other reports, it shows the level of assurance that authors of reports have given, as well as what the committee has given, whereas what we're interested in here is what the committee has given. Is that intentional?
No, and I was surprised to see it. I think it possibly was because last time when we did the new assurance for the first time, there was quite a lot of debate about the fact that the committee dropped some of the levels of assurance. So I think it's really there to show that there was more overall agreement about the levels of assurance. But I would agree with you, going forward, I wouldn't expect to see the author's suggested level of assurance on there. That's useful in the committee and needs to be on the committee reports, but we don't need it once it comes to board, because it's the committee level of assurance that board need to know.
Thank you, Jamie. And I saw a little wry smile on Jill's face when Jamie raised that point, because you obviously saw an email I sent her yesterday suggesting that all our different committee reports have got different styles of reporting their assurance. And I suggested we need to pick one and stick with it across the whole of the subcommittees, which I've left with Jill to have a look at. Thank you. If there's nothing else from workforce, we'll move on. Steve, F&P, please.
Thanks, Mark. Nothing to raise. Happy just to take any questions.
Does anybody have anything F&P? Okay, thank you very much, which leads us to the Audit Committee, Martin.
Thank you, Mark. So I take the committee, the paper as read. I just want to pull out, we still have a game of two halves in terms of our internal audit. Very positive response in terms of all the financial controls and processes. And I know we say this every year, but we don't take it for granted. And the 72-page or 72-question financial sustainability report that was done really pulled out and illustrated that we were, positive and we had the right financial controls and sustainability in process, and compare very favourably with other organisations, which remains very positive. We know that there are, we point our audit in terms of the more clinical areas at areas where we know we've got challenges as part of the change process, and we work very closely with the Quality and Safety Committee to make sure that those are, we're getting in the right areas and that we are making sure there are improvements, and we do follow those up. So I wanted to provide that assurance to the board that those are focused. And then the final thing to mention is that the handover of our auditors between Grant Thornton and Deloitte continues to go smoothly, and they're doing a review of the papers this month.
Thanks, Martin. Nobody's showing questions there. We move on to, so we take that as accepted, move on to charitable funds. Julie's obviously unable to be with us today, but both Steve and Jamie sit on that committee, and Martin, Robert obviously is the executive officer there. Does anybody have any questions of the report as set out and the actions that are being taken within the charitable funds? No? Okay, thank you very much. So we can accept the charitable funds committee's report, which takes us to the mental health collab. Jamie.
You'll see from the report that we are still, with Jill's approval, working to the earlier format approach to providing assurance. That's going to change from the March meeting. So this is the last time where we're looking at providing assurance to the old format. The main items for assurance come through the mental health executive, where there's an overall report and then specific reports on performance, finance, workforce and quality, and you can see the assurance levels we've given to those. Some of them we did not give assurance levels because of data problems, or the reports were not available for various reasons. And we've listed there a number of other issues that came to the committee. It's been operating a year now, so Sarah and Sue have been giving some thought to how we refresh and update the governance arrangements. That's a work in progress. Similarly, the cost of living support across the whole of the ICS mental health workforce, the voluntary sector, local authorities, GPs, as well as ourselves, that's in progress. Elaine's bringing the detailed version of that to the next meeting. We've got a report on the provider collaborative coming at the end of this meeting, so I won't mention that. Sarah referred to the mental health response vehicles in her report earlier. We didn't give a lot of attention to that. It's not referred to in here, but in its basics, what was reported to us was that the provision of dedicated mental health response vehicles is a requirement in the long-term plan. It's going to be funded by the Mental Health Investment Standard. The idea here is that we have fewer mental health patients taken unnecessarily to emergency departments, and where patients are detained under the Mental Health Act, more of those are transported via ambulance and fewer by police vehicles. West Midlands Ambulance Service have produced a business case for how they would provide that service across the region, which initially was supported by all the trusts, the West Midlands Provider Collaborative being the umbrella body coordinating this. But as the details emerged, something like half of the trusts in the West Midlands are now no longer happy. This is to do with data about volumes, number of ambulances, number of transport, and I think we're hopeful that that is going to be resolved. Certainly from our point of view locally, we would wish West Midlands Ambulance Service to provide the service, but I haven't got anything more to add to that. I don't know whether there's anything more recent in the last week or so, Sarah or Sue, to bring us up to date with that. No. Okay.
Thank you, Jamie. Does anybody have any questions on the Mental Health Collab? No? Okay, in which case I think it's about time for a break with your agreement. And I'd suggest we all come back at 2:15, if that's okay with everybody, 11:15. See you in a moment. Thank you.